Alrighty, I'll get started with these initial slides. And again, for everyone just joining, please make sure to sign in at the link in the chat. I know I've said it a few times, but there is the same link in the chat. I put it there twice. So if you have any questions about that, that's just for the CME credit. So welcome everyone. Thank you for joining today. This is the course, The Innovative Application of AI in Occupational and Environmental Medicine. And this is presented by the Selikoff Center, specifically presented by Dr. Nabeel from the Department of the Environmental Medicine. First, we wanted to do an accreditation and a disclosure. So if you see here on the right, we have our accreditation and our disclosure statements for this course provided to us by the Westchester Academy of Medicine. Number one here, certificates of attendance will be provided following the completion of this course. So just make sure you are signing in at the link in the chat. That is so I know who to send certificates to. And then it also, please complete the evaluation form that I will be sending following the course. Again, that is for the certificate's sake. I wanted to give everyone a brief overview about the Selikoff Centers. So the Mount Sinai Selikoff Centers for Occupational Health are committed to delivering cutting-edge clinical services with a strong emphasis on prevention, ensuring the health of workers and safety of workplaces. Our multidisciplinary team includes physicians, nurse practitioners, industrial hygienists, ergonomists, social workers, and workers' compensation and benefits specialists, all working to provide a comprehensive patient-centered care. We specialize in diagnosing and treating occupational diseases, assessing workplace conditions to identify potential risks to other employees, and recommending strategies to improve overall work environments. By identifying workplace hazards, we help prevent occupational diseases through targeted training and education for both workers and employers, and we implement effective workplace interventions as well. We have 4 locations. So we have the Manhattan Clinical Center, Staten Island, Yonkers, and Suffern. So we do cover the New York City region as well as the Mid-Hudson Valley region. If you have any questions about any of this, feel free to send me an email following the course. But with that, I'm going to go ahead and send it over to Dr. Nabeel to get the course started. Thanks so much.
Thank you, Daniel. I appreciate it. Let me share the slides. Okay, good. So hope everybody can see the slides at this point. Good.
We can see them.
Thanks. Thanks for having me. I'm excited to go through this topic. It's, of course, we hear about artificial intelligence all the time. We're now more so than what we used to in the past. So this is sort of a kind of also a journey for me for past 8 years that we have worked on this. And then sort of it's coming full circle at this point. So an innovative application of AI in occupational and environmental medicine. Most of the focus will be to really help you understand what exactly AI is and how it's been changing and how we can use it in the context of occupational and environmental medicine practice. And that's what I do. So it's easier for me to make the case for it. We also want to look at what's the practical implications of the AI use. Especially, I'll look into musculoskeletal disorders and the pain characteristics in musculoskeletal disorders. So over the course of the presentation, you will see how we can leverage this remarkable technologies. And then talking about the nuanced AI technologies, which are changing almost on a daily basis. So let's start with a case, of course. As a clinician, I always learn from the case. So this is a real-life case with names and addresses changed. A 43-year-old operating room technician, Sally, slipped and fell early in the morning while preparing a case. Floor was just wiped and it was cleaned, and like any other morning, it was a unusual morning for Sally. As she slipped and fell, she hurt her back in the process. We know that lower back pain is fairly common entity in injuries. It's one of the most leading injuries that we see in workers, particularly with physical jobs. Also, people like Sally, who is a OR technician, slip and fall is very common mode of injuries that they see. There are lots of things in our back, but primarily sometimes there's disc herniation, sometimes there's spondylolisthesis, the movement of the bone on bone. Sometimes arthritis makes it harder for us to treat lower back pain cases. In terms of Sally, we saw sort of degenerative joint disease as well as some disc herniation associated with the movement of the disc. And she was in significant amount of pain. She has radiation of the pain down into the leg. She has numbness and tingling sensation after the injury. Understanding the issue of lower back pain is extremely important. There are many of us who suffers from chronic lower back pain. We also have sometimes we do see lower back pain associated with other red flags like cancer or metastases to the bone. We can have lower back pain in that instance, but majority of us do suffer from lower back pain without a cancer etiology, and there are a bunch of it. For example, degenerative disc disease, scoliosis, spondylolisthesis, spinal stenosis, pregnancy, kidney stones, infection. There's a lot of reasons to have lower back pain, and it's one of the most commonly seen entity in the clinical practice. There's conditions related to disability, like arthritis, back and spine problems, heart diseases, and there's increased disability secondary to musculoskeletal conditions. So the value proposition here is, how can we minimize or reduce lower back pain in our patients? How can we effectively treat those individuals who are suffering from lower back pain? And one of the things that I want to highlight here is greater than 40% of the lower back pain visits are to family practice providers. And we can do intervention at that level to help minimize lower back pain patients, or at least morbidity associated with lower back. And we have a lot of people who work with Sinai. We have a lot of providers and practitioners. This is an older slide, but we have a number of hospitals. We have a number of clinics across the metro New York area in all boroughs, and we see lots and lots of patients, and many of them suffers from lower back pain, as we can see. But the challenge with treating lower back pain, particularly individuals who are not trained in occupational and environmental medicine, there is an element that's missing sometimes, that what I've seen. And I'm an internist as well, so I understand where the primary care doctors comes from, and how, as an occupational and environmental medicine specialist, how we see lower back pain patients. The tools that we use is basically help the injured worker who is suffering from lower back pain return back to work. And there's evidence to prove that sending them back to work basically helps with their recovery. As compared to occupational medicine doctors, we start with this process fairly early. There's ACOM guidelines, there's ODG guidelines to help us make that decisions for patients to come back to work. The challenge for the primary care doctors are they don't have the tools or sometimes expertise to really prescribe the actual return to work treatment plan for their patients. So the question is, can you work with lower back pain? And the answer is overwhelmingly yes. There's randomized control trials who actually support this idea of improvement in the care of the patients, particularly suffering from lower back pain, especially acute lower back pain patients. They can make them more functional. They can return back to work. And there's a significant difference in terms of resolution of pain if they are put back to work early on. It kind of helps with their treatment and therapy and management. And over, again, this notion has been proven. We used to do bed rest, not anymore. We need to move the patient mobilize them. And return to work is a good way to do this in an effective way. Coming back to Sally, unfortunately, things did not go really well for her. She started to have acute on chronic pain now. Most of the activity was fairly limited. She was given bed rest early on, so that didn't help. And now she's to a point where she required further intervention. She went through injections, spinal injections, and that sort of relieved some of her pain, but not a significant amount. And then finally, the worst outcome that we see, people with degenerative joint disease and a little bit of instability of the spine, we end up fusing Sally, which did not help with the pain, but rather makes it even worse. So she's now living with chronic lower back pain. Lumbar fusion surgery has been done, and she has not returned back to work, which was she was supposed to come back to work. It's hard for her to perform the essential functional jobs as a technician in the OR. Coming back to the point that primary care doctors or PCPs sees a lot of lower back pain cases. And this is a graph that we did early in our study to look at a number of people, the number of lower back pain cases that each provider see in a practice. And that varies over time. Most of the people see acute low back pain. Some have acute on chronic low back pain patients. Then some of us deals with chronic low back pain cases. And then the challenge to really decipher like what you're seeing in the practice is very, very difficult. This is just a small subset of how we code for ICD-10, how we use the codes, ICD-10 codes, to determine or describe lower back pain in our practice. So if you can see, the most commonly written code is lower back pain, and then rest follows accordingly, depending on what are you doing and how you're comfortable with lower back pain. So in lower back pain patients in clinical practice, we started to understand the frequency, variability, issues, and opportunities that we can have to address lower back pain. So we all use Epic. Epic is an electronic health record that's been commonly used around the country. So we decided to build a sort of a prescription for return to work for our primary care doctors. And it ended up basically, we integrated this process within the electronic health record. The primary care doctors can easily characterize lower back pain by acuity and then provide specific targeted intervention for their patients. We divided that into intervention group that got the tool in the electronic health record. The other control group did not. And as you can see, the intervention group did really well for their patients, recommended evidence-based interventions for their patients. But the problem was, over and over again, I kept hearing about the fact that, Dr. Nabeel, you don't know my practice. I'm dealing with acute on chronic pain. I'm dealing with chronic pain. Your system might not apply in my practice. And I've seen a lot of things, and they're right. They're right in that, in their statements, because most of the pain that we see in our practice, we cannot decipher between acute or acute on chronic pain. And that gave us an idea about improving the support in electronic health records to decipher that problem. But the problem with electronic health record is the information is a lot of steps that you have to take. We basically use a clinical decision support systems in electronic health record, which has a lot of components. You have to fix all the component, basically build a system for things to flow more effectively. So if the decision making is done, this is not a very nice process to work with. And if you are scaling it up to a provider practices or to a group of practices, it becomes even more cumbersome. So that gave us an idea about, at the time, deep learning, machine learning, artificial intelligence were kicking in a first gear. And this is some of the examples that You can see that people are doing things with AI. And this is early AI, which is artificial intelligence, machine learning, and deep learning aspects that we can see transforming the way that we do things. One of the things that really caught my eye was the natural language processing, which I was interested in. So we designed another study, and we looked at figuring out how we can really understand what kind of um, lower back pain seen in the practice. Because I don't have the ability to look at 8,000, 10,000 records. So we need artificial intelligence to decipher that and do it through a way that is scalable. So what we did was we used unstructured free text data, which is a provider writes a note and put it in an electronic health record. And then we basically use that unstructured data or free text to train our artificial intelligence to make sure that the AI can decipher between acute pain and a chronic pain. So, for example, this is a good example of how we write in the electronic health records or notes. This is a 24-year-old female with lower back pain for 2 days, referred for physical therapy and follow-up in 2 weeks. So deciphering that information by a computer is a very challenging thing. But we built a system that allowed us to decipher this kind of information in real time and can apply it when the providers are seeing the patients. And we used a process called natural language processing, which is basically a backbone of any artificial intelligence nowadays, but it started with NLP. So the computer can start to understand our language in a natural way. But the interesting thing that was coming together was that we also started to use neural nets. Neural networks think about it as a bunch of neurons in the brain, and they all come together to make a decision about a case. And in our case, we basically inserted, was this a lower back pain, acute pain, or a chronic pain? And then artificial intelligence made that decision, classifying them into acute and chronic pain. So this is a very visual or illustrative way of looking at a neural network, which works similar to our brains and can decipher information in a very quick and easy way, but in real time. But there are certain challenges we had. We weren't sure how to train our artificial intelligence. There's a lot of things that we classify lower back pain: sudden back pain, spasm, low back pain, sciatic, or use of medication that give us an understanding that this is acute low back pain. One of the things that I should address here is these words. When I read the note, it takes me 2 seconds to see if it's acute low back pain versus chronic low back pain. But for a computer to decipher these things takes a lot of time, a lot of practice, a lot of understanding. The other thing that people told me, and I use IC10 codes all the time, well, we basically code every encounter. So you can access IC10 codes to really see if it's a acute low back pain or chronic low back pain. But that's not the case. Most of the IC10 codes that we saw are not reliable, and they do not characterize the acuity of the lower back pain patients. So that with that information in mind, we started with very simplistically use the unstructured free text data. We looked at 15,000 records, 15,000 encounters basically, and 17,000 notes, and then able to extract lower back pain. We actually also annotate these free texts. So annotation means that I look each case individually. We looked at 4,000 cases and labeled them as acute or chronic. And that helped the AI to decipher or get trained for acute or chronic low back pain. And in this case, you can see that the AI actually extracted the right information to make a decision. So the experiment was really good. We were very early in our work to demonstrate the clinical notes. We can extract some really key information about lower back pain, and it's important for us because if it's acute low back pain and we can start improving the management of acute low back pain, we can do intervention at that time. So it was really important for the group to start to do this. And it has implications long term. But moving on, once we finished that project, of course, pandemic was raging and things were at the standstill. But there was another thing that was brewing around the scene. This is a very interesting Google paper that got published in 2017 early on, where the researchers demonstrated that the attention is all you need. And in a simple way to explain that, this is called a transformer model. This is not the transformer, the movie that you have seen before, but it's a transformer model which inputs and outputs. What it does is basically it keeps track of every single word that comes before it and makes an assumption about what comes next. So transformer is basically the backbone of all our systems that you see, ChatGPT or Gemini from Google, or other BARTs, which is also another transformer model. Everything is basically being assembled because of this work that was done earlier. So we used, when we started our next phase of this project, the next idea was to really not only decipher acute or chronic pain, but rather expand it to a point where we can look at acute pain, acute or chronic pain, and chronic pain in lower back. But that's not it. We also wanted to see the same acuity of pain in other systems like knee, shoulder, and other things. So we started with the same thing. We labeled and trained our artificial intelligence. We extracted notes from electronic health record. We looked at patient notes, we labeled them, and we labeled them as a back, knee, or shoulder. And then we also labeled the notes as acute, acute on chronic, and chronic. So extraction of the note from electronic health record, patient notes, and expert labeling. And then we went to work. One of the things that was emerging at that time was a open source model called Llama 7B, or 7 billion parameters. This is a open source, just like ChatGPT model that was released into the wild by the company Meta, which is Facebook, and we can use this and install it into our systems, and nothing with the electronic health record goes out the system. So it was an easy way to address that. So everything we build internally and use Llama brains, which is the model, and train the model to really understand how to decipher chronic pain. If it's a acute shoulder pain, chronic shoulder pain, acute on chronic shoulder pain, or vice versa. And what we saw is we can actually give instruction to this model, say what did the note say about the pain. We can actually input the actual case, and then it deciphers, is it acute on chronic low back pain or not. And that was a very simplistic design at the time. But one thing that was really interesting about this work when we started this, that nobody has done this before our time, because the big large language models were never used to decipher musculoskeletal conditions. The other discovery was very, very interesting. We can not only ask the model to look at chronic, acute, or chronic, acute on chronic or chronic pain, we can also ask the model questions that are not related to pain. For example, in this case, we're chatting with our model to say if this particular case has chickenpox, in the past. And the model accurately pulls the information out and tells us that, yes, that's the case. So what changed with the large language models or the new AI was that it was not restricted. We were not only have to train the artificial intelligence for one kind of classification, but it can be agnostic to any kind of problem. And that opens up a whole different area that we have never seen before. So if I want to ask somebody that he or she has hypertension in the past, the large language model can tell me exactly if they have hypertension in the past or any other conditions in the past. And that really helped us understand that the potential of the new AI that we're seeing. But the challenge is still immense. So this is just to give you an idea about how well we document. So this is the number of tokens, or think about like a words that's been used in an electronic health record to write a note. And the majority of them are short, but major times we see a good amount of information is in between 1,000 to 2,000 tokens, which is where the most of the people write their notes. And then we also see an outliers where people have written a lot longer notes. The challenge with this is the longer the notes are, the more computational power the large language model use to decipher things moving forward. And it was really interesting. We actually used the large language model to not only have a good sensitivity analysis, so the model can really accurately predict it's a shoulder pain, low back pain, knee pain, or other kind of pain, but also fairly specific in terms of what it can see. So it has a good recall, it has a good sensitivity. It was really interesting to see that acute pain and chronic pain can be really deciphered by just one model. And that was truly amazing at the time. And again, this is early times when ChatGPT or OpenAI released the ChatGPT in the commercially. So talking about generative AI, there are a lot of models now on the horizon, and especially the people are using these models in their clinical practice. So if you look at the left-hand side of the screen, you will not see occupational and environmental medicine practice. It's not listed here, but majority of cases where we see epidemiology, biostatistics, cell biology, and GI has been actively using these models to decipher and to do things with them in clinical practice. And there's commercial models available, there are open source model available. So there's a lot of changes that has happened since we have started this. But I want to bring you in for what the nuance in our models are, which is really changing in a very, very significantly rapid pace. The one, if you look at if people have used ChatGPT or others, that's more commonly known large language model that people use. It's a chat program. People put in a simple question and get a response out. Most of the early ChatGPT model worked in this setup, which is simple response model. You ask a question, it gives you an answer, it provides some direct generic information. It offers basic facts without any personalization, and it's limited to surface level sort of recommendation. And that's where we saw a word that we use in our case is hallucination. The language models are huge. Sometimes if they don't get the answer, they hallucinate or they make up things. And people saw that early on. Things have been changing and improving over time. So this was the first type of models that were released and still continues to be released at this point in time. Anthropic or ChatGPT or others have similar models called simple response models. The next thing that came on the horizon is called chain of thought models, which was somewhat different from the simple response models. They demonstrated visible sort of thinking process, which is really unique to humans. So they can start to think. They start to really look at multiple possible causes, and they are called chain of thought models. They ask clarifying questions like all of us do. when we are unclear about things. So they were more human-like, I would say, that we started to see. And then they provide a more structured response based on available information. But there was still something missing. The missing part was a reasoning part. So we started to see now a reasoning large language models that employs systematic reasoning, which was not available with chain of thought models. And they can build differential diagnosis. They can look at probability and decision trees. They can look at other kind of avenues to make a case and to provide you an answer. Think about this as a medical student when you're thinking through a problem. You are one of the reasoning LLM models, which is making a differential diagnosis about your case. And that's exactly what we're seeing now in reasoning LLM models. And they can integrate evidence, different approaches from different places and give you a very concrete, good response. And that also decreases hallucination of the model, also gives a direction to the model and what we can do to assess. So give you a good short example, again, lower back pain, simple response model, and the left will give you this kind of answer. So I have a low back pain, and then immediate response gets generated, that it might be caused by herniated disc, muscle strains, rest and see a doctor. So the simple response model is very quick to respond to you in a very simplistic way without taking into account other things that's going on with you. I asked the same question to chain of thought model. I have a lower back pain, and then it will go through multiple steps, consider possible causes, evaluate the severity of indicators, consider medical history, and then formulate a response. So low back pain could be because of multiple causes, should consider duration, location, radiation. So all these things are usually happening when we think about the problem in a linear way. But what happens with reasoning models, which completely changes the infrastructure completely? The same query, I have a low back pain, and then there's an internal reasoning process that start to kick up. It basically goes through differential of musculoskeletal causes. It looks at structural issues. It looks at inflammatory conditions, age, trauma history, constitutional symptoms, pain characteristics. A lot of richness in terms of making a decision before it gives you a response. And that's what we are seeing in terms of reasoning models. So before they process the information, they actually go through this multiple steps and then give you a response, which is much more accurate and basically in tune with what you're asking. But one of the challenges with the reasoning model is it requires a lot of computational time. It requires a lot of understanding of what has been asked. So it takes more time to respond to your question. So I'm never fulfilled by sort of without having my own generative AI model. So this is a very simple example of building a very simple generative AI model using Llama, which is an open source model. So this was early work. We fine-tuned these models. We can run them into HIPAA compliant environment like hospital environment. We don't need to take them out. So none of the patient information goes anywhere except stays within the hospital systems. And one of the things that has really changed over the course of couple of years is we have now minimized the computational piece. At the time when we did our first study with generative AI, it requires us to run these computers for days. And now I can do this work within my laptop or desktop, which is just liberating in terms of that. But one of the things that really helped me is I can design the way I can solve the problem. So we can do control, we can do cross-validation, we can build AI based on my clinical practice, which is very, very interesting. And then can provide an explanation because I know the cases and I can evolve the model the way based on my clinical practice. So in order to do that, in order to provide this context to a large language model, there's one of the things that we also do. So this is a paper on lower back pain and return to work. Most of us who are clinicians, if you want to learn about something, we go back to the scientific reviews, we go back to the literature, and extract some of the most important salient points and to educate ourselves so we can make the right decision for our patients. In this case, this paper, which is an old paper, 2007, comes from American Family Physician. It talks about modified duty for patients. It also talks about signs and symptoms and psychosocial risk factors for absenteeism. So all these things are pretty much built into my practice. I look at all these things to make a decision about my patients, especially suffering from lower back pain, and see if they're able to get back to work or not. I can do the same with basically the AI models. So AI, or generative AI, that we are talking about, that can sequentially think, they can have a brain of itself. We can actually inject these documents into them, this is the way that we can train them on our practice. We can train them on the knowledge that we have. You can also train them on the multiple knowledge that exists, and make them more biased to how we think, and get the response from them the way we would like to have. Because with experience, education, and things, we're able to make a much better and quicker decisions than anybody else. So if we can instill that knowledge and inject it into the large language models, they actually work and perform just like you. And this particular process is called retrieval augmented generation process, called RAG. And it retrieves information from you. So again, going back to the reasoning models, this is some of the examples I want to showcase to give you an idea about how we have basically played around with it with cases. So simple response model is the first example. So on the left-hand side, there's a human analysis, a human person writing the notes. We're messy. We don't write really well. We try to keep things so we can understand quickly and then move on. So this is a analysis done by humans. The case was written by a human. So this is a lady who it's a patient handling injury with strain and injury, and injured the lower back. And we see all the elements here. But we can run the similar case through AI, and it start to make sense of what has been in the note. So when you ask them questions like, is it work-related injury? The answer is yes. Is there alternative diagnosis to this injury? And based on the case that was given, AI can actually tell you, yes, there might be an alternative diagnosis for that case. So this is and then it can summarize the case. It can give you a simplistic understanding of the case. So it's a certified nurse assistant, or PCA, which was injured by employee while performing patient handling jobs. So it allows you to summarize things in a very simplistic way. Let's look at the chain of thought models. And the next example is of chain of thought. Again, the example on the left is a human-based analysis, which talks about this person or patient was struck at work. And basically, this is a claim analysis where the insurer is looking at the claim and basically denied the condition. One of the things that is really interesting why I put this case is the injury didn't occur within the hospital premises, so it was outside the hospital premises. Thus, it's not work-related injury, which is what the conclusion was from the human analysis. But look at chain of thought analysis. I didn't ask the question here that the person, this injury was outside work or not work injury, but I asked the question, was the employee kicked? And just by reading through the note, you can actually see the patient was kicked and stabbed by a fellow worker. but kicking is a very specific phenomenon that were pulled into this setup, and you can actually at the end the AI can draw a conclusion that the patient was kicked during altercation, and which is very important to understand. So chain of thought analysis is a really interesting way of making inferences based on stepwise approach of asking questions. And internally, the AI start to ask questions, what's relevant to give you a response. And then finally, the reasoning LLMs is a whole different level of understanding. In this case, again, it was a strain, a lumbar disc herniation on the left, and we can ask a number of questions for reasoning and LLMs to make an inference. But what they do is they go back to your first the literature that you have provided them to make sense of what you're asking. And then they will extract the most important points from the literature to answer these questions. And again, I used the American Family Physician article of 2007 to educate the LLMs to answer these questions. And similar ways is start to reason. Again, the questions are the same, and it gives you a clear understanding how the large language model or reasoning large language model is thinking. They're thinking about the risk factors. They're thinking about how we can incorporate those risk factors into response, the final response. And again, extracting information from the article. So finally, they can give you a response that this patient has a lumbar disc herniation, a radiculopathy following an injury at work. This case also have a history of back problems. So it's a acute on chronic case. And there's a lot of challenges for pain management and return to work status. How significant that is, that the large language model, which has nothing to do with my practice, nothing to do with seeing patients, are starting to experience this phenomena of reasoning and coming up with the answer that is more controlled. It is not saying that this person will do exactly well. It's actually telling us that this person we might have a challenge moving this person forward and providing the treatments, which might not have the outcome we're looking for. He or she might not be able to get back to work. And then it describes the medical management. It provides other kind of information that you can do with this information. There are also psychosocial consideration, because as I mentioned in the past, the articles also includes the psychosocial consideration, and the AI model is also incorporating that psychosocial components to the case, that how we can address return to work challenges. So very, very sophisticated answer that we didn't have before in the past when we started this journey. And then temporary modified duty might be another viable option for return to work for these cases. So at the end, there are lots and lots of things that we can do with large language models, particularly the new version of reasoning models that has a direct impact on our ability to treat patients. And here's a quick example of how to build one systematically. We basically train the large language model, as I've explained, through documents or to evidence. And in this case, I want to train them for acute on chronic, and chronic pain, to decipher that, to extract that from the electronic health record. And think about the ability to do that. Like if I have 10 million records, 11 million records, out of that, they can extract all the necessary cases for me who fit these criteria. The second part that is really exciting is also you can also ask them to build synthetic cases. So not all the cases that you train them with might cover all aspects of low back pain. So you can design and develop your own synthetic cases based on the real cases. And those could be used as edge cases or non-edge cases. Some of the good example for this is Grok 3 that's been released by, that's a large language model that came out, which actually used synthetic information to train or to improve on the model, which is very exciting in this sense. The other thing is you can also train with real cases, of course, and then help them understand real cases in real time. And then classifying it in a way that allows you to process them. So if I have 11, 10 million records, I can see subset 30%, 40% of them basically represents acute low back pain. 30 or 40% represents acute on chronic low back pain, and then the issue of chronic low back pain. How important that is if you basically untangle them and then focus on the acute low back pain and where the intervention is going to be, and how you can educate the primary care doctors or physicians or providers who are taking care of these cases, and you can target your interventions on those cases. So a game changer by all means in terms of our practices. And then finally, one of the things that I always hear, and I think I also consider that, how do they come to this conclusion that this is acute low back pain or chronic or acute on chronic low back pain? And one of the things that it does do is the reasoning LLMs also provide you the back-end information about how did they come to the conclusion of what it is. And this is on the right-hand side, some of the reasonings or key points I've extracted from their reasoning, because now you can also get a way how they're thinking that gets posted as they come to a conclusion. So it's not a black box anymore. It actually allows you to think and see how the intervention is done, how the reasoning is done, and how the answer has been extracted. And finally, I'm going to actually showcase one of the cases. This is a 35-year-old male construction worker with lower back pain after heavy lifting. There's denizing numbness and tenderness. There's no prior back injury. So it's a pretty straightforward case. Positive straight leg raising test was positive. Mild tenderness was there at L4, L5 region. X-ray was essentially negative. So what was a likely diagnosis? So I think most of us will tell you that this is a simple acute low back pain, more mechanical in nature, because he's lifting or he has injury doing construction work or poor lifting techniques. And is this acute low back pain? Of course, this is acute low back pain. So let's see what the reasoning goes through. And it very much precisely identified the problem as acute non-specific lower back pain caused by heavy lifting. And also argues in terms of there's no straight leg raising test was positive, may suggest that possible lumbar disc herniation, but there was no neurological symptoms to pin that into disc herniation. And the final part is this acute low back pain? And yes, it was acute low back pain. There was no red flags to pinpoint if it's a significant weight loss or history of cancer. So if you're giving a good case, if you are extracting, or if you want to extract some cases, LLMs can do the job for you in a very simplistic and very informative way. And finally, I just want to highlight the point that I had a privilege to do OCPOD, which is a podcast hosted by American College of Occupational and Environmental Medicine. And we have a series of work that we do, but this is episode 59 talks about artificial intelligence, OEM, and how the biases that we see that we need to account for. And that concludes my presentation. I hope that you had fun, you enjoyed it, and I hope that you will see the use of electronic health, use of artificial intelligence in our practice more and more. Thanks so much.
Thanks so much, Dr. Nabeel. I just want to let everyone know, firstly, that there's a Q&A. And if you have any questions for Dr. Nabeel about this, anything he presented on, we have about 10 minutes. We can go through some of those questions. Go go ahead and submit those. Also, if you did not sign in at the link, please do that. I'm also putting now in the link another REDCap survey. This is the evaluation form for the course. If you would like to receive a certificate, please make sure to complete that evaluation form. And I will email all certificates to all attendees by the end of the week. All right. We'll wait just a couple minutes here, Dr. Nabeel, to see if anyone's typing questions in the chat. But then, yeah, it was a really great presentation. Thank you so much.
Oh, my pleasure.
One thing is, Dr. Nabeel, did you say there is one of, I know you have the occupational podcast. Do you want to provide a little bit more information on your podcast and maybe if there's any episode specifically? I think there was an episode specifically on AI and this topic, but if you want to provide more details to everyone so that they could listen in.
Yeah, sure. Thanks, Daniel. OCPOD it's a podcast specifically for occupational and environmental practice. And we basically reach out to different experts around the country and talk about different topics that is related to the practice of occupational and environmental medicine. We started the OCPOD at the time of pandemic, and so initial episodes were focused on the pandemic and the practice itself, and then later on episodes also have, as I showed, conversation about artificial intelligence. We have some recent episodes on LA wildfires, where we talk to some of the providers who is one of the providers who's living in LA, and she basically experienced the event. So it's an interesting way to connect with the community. It's an interesting way to really understand the nuance topics that's coming in occupational environmental medicine. And I think going back to the AI side of things, we have less involvement. Like I think personally that we can use more of artificial intelligence in our practice. The challenge is how to make a path for it. How do you build that expertise around you? Most of us are also clinical informatics trained and specialize in it. So we have an opportunity to really take a lead on this and develop sort of areas of expertise within medicine so we can leverage it. So there's more to come for sure. I just shared with you some of the exciting development that's been occurring in real time.
Yeah, thanks so much, Dr. Nabeel. Any other questions in the chat or submit into the Q&A? We have a few minutes here. And again, just make sure you are completing that evaluation form in the chat. Even if you don't need a certificate, please just go ahead and complete it. We do submit these evaluations to the Westchester Academy of Medicine. So we would appreciate if everyone could submit that evaluation form. But I don't see any other questions in the chat, Dr. Nabeel. Was there anything else that you wanted to discuss or provide any information on?
Yeah, so one of the things that I would encourage the participants to ask the question. Sometimes like you don't have the expertise yourself, but there's somebody else who are willing to work with you. I think that's the best way to learn in terms of how you can leverage artificial intelligence. Again, like any other clinical practice, make sure that you do not include personalized or private data and send it to any place unless you're absolutely sure that the whole process is HIPAA compliant. But you can certainly test the systems or at least enhance your ability to understand more how you can use AI in practice.
Absolutely. Well, thank you. With that, I want to thank you, Dr. Nabeel, for hosting this course. This was very insightful. And I want to thank everyone for attending. I have put my email address in the chat. If you have any questions, follow-up questions for Dr. Nabeel, feel free to send me an email. I will get those questions to him. And I also, again, will be sending out certificates by the end of the week. Oh, we do have a question in the chat. So we have 4 more minutes here, but we received a question. Did you compare Copilot, LLAMA, Gemini, and ChatGPT for the same task?
Right. So it's a good question. So Copilot is a Microsoft product. It's basically built into the Microsoft products. Llama is a Meta product. Gemini is a Google, and ChatGPT is Open AI project. The Copilot and ChatGPTs and Gemini are closed source systems and require you to send information to them in a cloud-based system. In our work, we are uber focused in keeping information within HIPAA compliant servers and not to release that information anyplace else. So we deliberately use something that's open source that we can control all aspects of it. And Llama at the time was the open source element. You can certainly develop pipelines using the more proprietary based systems, but that's with a keen knowledge of you're using it in a HIPAA compliant sort of environment. So that was a limitation, and that was deliberately done in our case. In future iteration, I have used other open source based models. DeepSeek is one that is more reasoning LLM that use Reason, which is also open source, and you can use it in a controlled environment. So those are things that's very important to understand.
Thanks, Dr. Nabeel. And a follow-up question is, can the patient de-identified data be used for the above purpose?
Yes, absolutely. Again, de-identified, again, patient information is very, very important and crucial. We don't use anything that identifies the patient. You can create synthetic cases. I think that's the best way to do this, based on the real cases, and can use that in terms of testing the model or looking through it. So you're basically shielded from any real information going into any servers.
And with that, I think that's all of the questions within the question and answer. So thank you for submitting those. And thank you, Dr. Nabeel, again. We really appreciate it. And thank you to everyone who attended. If you have any questions, again, shoot me an email. We will have some more CME courses coming up in the future. So just continue to follow us on Instagram, LinkedIn, all of the above social media platforms. We post about them there. And again, thank you all. I appreciate it. And with that, we'll go ahead and end this course. So thanks so much.
Thanks so much. Thank you.